Dr. Eugene Santillano is the Chief Executive Officer of Addiction Change Expert ACE Medical Incorporated. He is a dual board certified specialist in addiction medicine by the American Board of Preventive Medicine, ABPM, and in family medicine by the American Board of Family Medicine. Dr. Santillano has been practicing medicine since 2003 with expertise in primary care that allows him to advocate for health equity and his interest in healthcare policy. Addiction Change Expert ACE was founded in early 2024 to educate and reduce barriers in addiction treatment. Dr. Santillano also aims to offer practice change consulting dedicated to help physicians integrate addiction treatment into their own medical practices to ensure comprehensive patient care. How are you doing, Dr. Santillano? Nice to
Great.
join us today.
Hello, Ronald. It's great to be with you here today. Thank you for inviting me to join you on Behind the Stethoscope.
Thank you, thank you. So, Dr. Santillano, you had a diverse career in family medicine, including graduating medical education. What inspired you to pursue this path, and how your passion for addiction medicine evolved along the way?
I would say that this has been a journey and not necessarily an end destination. The journey started with me recognizing that I do value education and teaching, and my first 7 years in practice were in residency education. Through time, I was trying to involve myself in the opportunity to develop a residency training program here in Santa Cruz County. I'm very pleased to know that a program is being developed, but because I'm not involved in that program, I decided I needed to reinvent where I was going to spend my time. And in 2014, I was working at the County of Santa Cruz, and I was invited to start supporting clients who were using buprenorphine in their opiate addiction. And what I recognized was that addiction is something that we all do in our medicine practice. In family medicine, we are all screening for nicotine, tobacco, right? It's something that happened in the laws. It's something that's happened in the policies and procedures. Almost every intake questionnaire includes a question about nicotine. And nicotine medications were something that were really new as I was starting my early medical journey in the 2000s. And they've evolved so much that now nicotine is available over the counter.
Yes.
You can receive medications to help you with your nicotine addiction at any 7-Eleven or CVS and Walgreens. And so we've normalized the treatment of addiction with medications for nicotine, but we haven't yet evolved to include those type of treatment opportunities in other addictions. And I'll tell you, one of the things that's true is we're seeing a lot of news about opiate addiction. And opiate addiction is important, and I definitely am interested in helping connect people to care that deal with opiate addiction. But the number one addiction, the number one substance used in this country is alcohol. And the substance that causes the most death in this country is alcohol. And it turns out that there hasn't been a lot of new medications to help treat alcohol use disorder in the last 20 years. And the medications that are available to help people treat alcohol use disorder are cheap, and everyone has access to them. And we can definitely start incorporating them into our everyday practice. And so the difference is that we have to be willing to screen and then willing to deal with those screening results. And part of it is sometimes our own judgments about what alcohol use or safe alcohol use or healthy alcohol use might mean. I've seen some rhetoric about, some alcohol may be beneficial, right? There was some talk about 1 glass of red wine may be beneficial for heart health. And what I can say is that depending on who you ask, you're going to find benefit. If you want to ask the cancer doctors, zero amount of alcohol is beneficial, right? If you want to ask cardiologists, maybe there's some benefit for alcohol for reducing cardiovascular disease, but in a very limited quantity. And it's very rare that I see people consuming alcohol in this very limited quantity. People will say, well, I only drink half a bottle of wine. And half a bottle is already in excess of the amount that is considered to be potentially healthy, right? Mm-hmm. So will I say that there's no role for alcohol use? I'm not going to say there's no role for alcohol use, but I will say that people are self-medicating. What I like to recognize is that we are all providing medications for addiction therapy in the form of nicotine, and we can all incorporate medications for addiction therapy with other addictions, including opiate therapy. You know, it's been amazing that the government has reduced the barriers. It used to be that there was a special license that you needed to apply for in order to prescribe buprenorphine. And buprenorphine is one of the 3 FDA medications used for opiate use addiction or opiate addiction. One of the medications is methadone. That's not accessible to the typical primary care doctor because you need a special license in order to use that medication. But the other 2 medications, one of them is naltrexone. Naltrexone has been FDA approved in an injectable form for both alcohol and opiate use, and which is available in various forms. And these medications can actually be very beneficial for people who are trying to curb their enthusiasm towards their addiction. And do people need to be on these medications long-term is often a question that I hear. And the answer is, who knows? You're going to figure that out. You're going to, on your journey, decide whether or not these medications are serving you in a way that is deleterious or positive. And I'll say that if your behaviors change using these medications so that you're able to re-engage with your family and you're able to re-engage with your employer and you're able to, or with your career, I shouldn't say employer because some people are business minded, but if you're able to re-engage with life, then the medication is doing a great service for you. And so are medications available for all addictions? What I'll say is that there's a lot of crossover. And that's one of my favorite things that I've learned as I've been treating diabetes. And there's this great medicine out there for food addiction. We call this obesity, but people have, you know, a propensity to overeat. And food addiction has been really taken by this new class of medications called GLP-1s. There's additional medications out there and additional receptors that are being targeted, but the GLP-1 class of medications has been an amazing benefit for diabetics. And one of the amazing benefits has been weight loss. And so now we've changed this medication and we've repackaged it. The same medicine has a new name, and now we're using it for obesity. The truth is that when I started treating people who qualified for this medicine early for diabetes, their alcohol use was also reduced. And so there's this cross reaction between different medications. And the truth is, these medications, when you're talking about addiction, addiction is really something that's happening in the head, in the brain. A lot of times it's related to previous trauma. And so whether it's a food addiction or it's alcohol or it's nicotine or it's opiates or benzodiazepines, any of these addictions, including non-chemical addictions like screen time and gambling, these are also addictions that are likely all coming from the same place, and that people are trying to survive. I really appreciated that if you look at a thesaurus, there is a synonym for survival, and that's coping. And everyone sees substance use as a coping behavior. So if we repackage that and say, well, substance use is a survival behavior, it becomes a little bit, less difficult to give someone compassion and say, well, man, you are surviving in a way that doesn't make sense, that we can help you to survive better. We can help you to survive with a healthier method. Medications are not without side effects, right? So I'm not saying that none of these medications have side effects, but the ability to re-engage with life is really the goal. And over time, we can develop a toolbox of coping behaviors that are different than substances so that hopefully you can remove the medication later in your lifetime or in your storyline.
So, you open up about the different medicine or medication that your physician or your colleague uses too. Now I see too in the media they kind of pushing up about Narcon, and I think it's for me, in my opinion, it's sometimes over like trusting that medication. You know like you said, right? Every medication has their use and limitation. So, in your opinion, are in that bridge now that Narcon is maybe one of the solution for opioids addiction?
So I think that you bring up a couple of ideas in that question. The
Mm.
first is, what's the difference between prevention
Uh-huh.
and in medical speak when we talk about treatment, right?
Mhm.
There's a difference between prevention and there's a difference between treatment. One of my favorite quotes that actually comes from family medicine talk about our value for ourselves as a specialty is that an ounce of prevention equals a pound of treatment.
Wow.
Okay? And so the idea is that you're right. If we're using Narcan to help people reverse the overdose or the overuse of an opiate, it's late in the game, right? But we're in an emergency mode. We're
Yes.
trying to help someone overcome something that they did already. So
Mhm.
if we can prevent that, that's even better.
Yes.
And we can prevent somebody from moving in the direction of addiction, that's even better. But when we are in a position where we are required to respond to someone who's already overdosed or already used a substance that they may not have known that they were using, and that's the case that I see, for example, in teenagers who think that they're using Xanax at home because of anxiety, and they heard that Xanax is a great medicine for anxiety,
Yes.
and they're receiving a pressed pill which looks like Xanax, at least it has a resemblance of Xanax, but it's actually fentanyl. And they take
Oh.
that medicine for the first time and pass away at home because they didn't know that they were taking something. So the question is, why were they taking something, right? At home, alone, not in a party situation,
Mhm.
right? So there's obviously other things that are happening in that life that they've decided to take that survival behavior into their home, and then it ends up being a deadly response. And so let's think about Narcan a little different. One of my favorite analogies was brought by an organization in Santa Cruz called HIP. And in this analogy, Dr. Jennifer Hastings used the analogy of a fire extinguisher, right? We often have fire extinguishers in our home.
Yes, we do.
Do any of us expect to have a fire? The answer is no. Do any of us hope to have a fire? The answer is no. Do any of us feel like it's a good idea to be prepared in case there's a fire? The answer is yes. And so if we use Narcan as an analogy that we don't want to have these emergencies happening, we don't
Mhm.
want to have a fire in our home,
Mhm.
but if all of a sudden we're confronted where the situation is that Narcan could be a potentially life-saving intervention for someone who is taking too much opiate, well, then it's a good idea to have it in the home. It's a good idea to have it in the car. It's a good idea to have it in your backpack, right? So I think that when we reevaluate what Narcan really is, it's more like that fire extinguisher. It's an emergency opportunity to reverse someone's overuse of an opiate, which causes respiratory depression. And the reason why people die is because they don't have enough oxygen going to their brain. And this medicine helps reverse that poison so they can hopefully start to breathe spontaneously.
All right. So, I mean, I said I said in my introduction about you. You've been, in the medical field since 2003. I know you have different kinds of colleagues now that you interact with, work with. Do you see the difference between the seasonal physician who is working, decades and decades, and the younger physicians coming in, maybe less than 10 years, how they treat people or how they approach their patient or client?
This is a really interesting question. I don't think it's one that we have discussed in the past. So I'm going to go ahead and tell you that there is a big challenge. And one of the big challenges that we talk about is a shortage of primary care physicians. And why is it important to identify primary care as the shortage? The reason why it's important to identify primary care as a shortage is because when populations have a high number of primary care providers compared to the specialists, that population tends to live longer and spend less money, right?
Oh.
So when we focus on tertiary care, so hospitals like San Francisco or hospitals in Los Angeles or hospitals in New York, places where they have a lot of specialty care, you'll see that the cost in the last year of life is tenfold times as high as it is in more rural places where someone is more connected to a primary care provider. They're more likely to be connected with things like palliative care and hospice care than when they're connected with specialty care, because specialty care, they do what they do. Specialty care is used to offering the most current and sometimes the most expensive interventions to try to help prolong life. And the question is, how much does that cost? At what cost are we prolonging life, and how much are we actually prolonging life? And it turns out we're not doing a very good job of prolonging life, but we are doing a good job of spending a lot of money to prolong that life for up to a few months. So it's very interesting when you look at the different ratio of specialties. And now let's talk about the question that you asked was, what about the new doctors that are coming in?
Yeah.
And I'll say that the new doctors that are coming in are really focused on lifestyle, right? And so the doctors that were practicing 30 years ago, before me, they were burning their oil, right? They were starting early in the morning. They were working late at night. They were doing a lot of their own care. They were working in the office and working in the hospital. So they were, managing patients in multiple locations. And we just don't see that happening as much anymore. We don't see people doing the full scope of their practice. They want to say, okay, well, I'm going to be working only in one condition. And the estimate that I heard is that it takes at least 2 new graduates to replace every retiree, right? Okay. And so right now, our current thought is, okay, we're going to replace every retiree with 1 graduate, but the workload difference, the older style physicians who were working and burning the oil all day long, we're seeing probably twice as many patients as our young physicians that are coming in. And our young physicians are demanding highest wages, highest benefits, and probably seeing half as many patients. So it's very interesting, that the shortage is actually much bigger than we expected, because if it's going to really take 2 new providers to replace our older providers, we have a significant shortage as this population continues to retire. And so they are trying to address that. We are trying to address how people survive in this industry, because honestly, people that were working, burning the clock, we know that that's not great for health, and it's not great for your families, and it's not great for anything. So is there a problem with us asking for a different lifestyle moving forward? There's not, but it does mean that we're going to create a hole, if you will, in the opportunity for providers to give care. And our population is growing, especially with the elder population. The elder population is living longer than in the past. And so we have this aging population in the baby boomers, and we need more doctors to provide care to this population, not less. And the baby boomers don't understand technology the same way that young people can. And so the young doctors who want to provide all technology-based care aren't necessarily going to be able to reach the baby boomers, which is the big population that's growing right now. So it's an interesting idea that we need to really understand the shifting market, and then also the shifting provider type of a practitioner, because it's not the same as it was 30 years ago. The money's not the same, right? There was a lot more money in medicine. There was a lot more benefits in medicine. Now that there's a lot more third-party contracts because of insurance, a lot less direct patient to provider relationships, it changes things. That's one of the reasons why we actually have movements towards moving back towards direct or membership-based care. I think that they're overusing the word concierge right now, because
Yes,
the
yes,
true definition of concierge is really kind of a customized care. I'll give you what you want when you ask for it. When I think about concierge care, I was thinking about someone who was taking care of we'll say a celebrity that works in the music industry, and they went to all of their concerts so that after they perform, they give them an IV. Now that's concierge care. Having access to your doctor is not concierge care. It's just having improved access to your provider. And so I think that the health industry is using buzzwords that's not truly providing the type of care they think they're going to be providing. Having access to your doctor is something that we all want to do. We want to have access so that we can be there for you when you need us. But when there's a lot of tasking going on, it's difficult. That's one of the catch-22s of technology. Yes, all electronic medical records make your charts legible, but it doesn't make the provider's life any easier. It actually has made life worse in a lot of ways. The estimation is about 2 hours of electronic charting time gets added on to a provider's life when they're using an electronic medical record. So it's going to take some more AI kind of solutions in order to get to a better place where AI will be charting for us. AI will be, creating some of the task automation so that the doctor's not asking you about your colonoscopy. You're just getting a phone call from some AI chatbot that says, hey, you haven't done this yet. Can we get you in to get your colonoscopy? This is the ways that you can accomplish that. So there's definitely some future innovations that will help us to provide better care. But it's interesting, the question about new docs versus old docs, because I think that we're really talking about needing to have additional ways to support providers in order to keep them interested in providing full scope family medicine or full scope care, because it's really easy to say, oh, I'm going to ask someone else to do that because it's just paperwork. Paperwork sucks, right?
I know. Even me, in the financial industry, we don't like paperwork. But I wanna basically dive more deeper than that, because culture sometimes play a lot of effect on how we approach, as a patient approach a doctor. When an old doctor said, "Oh, I'm the doctor, follow me." When this new generation, I feel like, "Oh, why do you feel like that? Why do you can you tell me about more of that? They're more open. Is that my misunderstanding, or just not really the case?"
Yeah. So one of the truths about the delivery of healthcare is, in the traditional delivery of healthcare, it's delivered in a very paternalistic, top-down kind of way, right? The physician is seen as someone who's at the high end of the respect scale. And so the doctors also feel that way. They're like, okay, do what I say and you'll be healthy, right?
Yes.
Take 2 of these and call me in the morning, right? But the truth about the way that medicine has evolved in the education is that we want to try and provide informed consent. But informed consent is more of a situation where we are really advisors,
Okay.
right?
Yeah.
I'm an advisor for health, right?
Uh-huh.
I am not actually in a place where I should be telling you what to do. I should be advising you what your options are, and then you can help me understand which of the options that I've presented fits best with your goals, right? And that's really kind of the difference. And that takes time. That's one of the truths about delivering that kind of care, is that then a conversation, instead of me just taking a little bit of information and spitting back a solution,
Yes.
means, okay, well, let me find out where you're coming from and what's going on with you. And then let's talk about, okay, well, what's the likely cause right? And what's the workup look like if we don't know what the diagnosis is yet? And if we were going to be treating that, what are the options you have for treatment, right? And so that is not something that happens in 2 minutes or 5 minutes. I don't know how healthcare systems are expecting doctors to actually provide that kind of best care without giving some, wiggle room for time. Really, when we're exchanging our time, right, that's where our value comes in. Time is one of the most limited resources, and I can only do one thing at a time, right? And if you're asking me to do more than one thing at a time, you're actually asking me to do distracted tasking, right? They call it multitasking, but it's really distracted tasking. We can't really provide true multitasking, high functionality. What we can do is distracted tasking. And if I'm distracted tasking, I'm really not going to give the best to anybody at the same time. But if I'm giving one person my individualized attention, then I'm able to give them the best that I can at that moment and provide additional resources when I'm not able to be the best resource at that time. And that's where consultations come in, right? If I am not the right person to answer your question, then I might have to involve someone else. But when people come in asking for a consultation as their first question, it's actually a little challenging because most things don't require dealing with, and I help you figure that solution that meets your needs. A good example is diabetes. Most people don't need to go to an endocrinologist because they're diabetic, right? Is it true that an endocrinologist may approach diabetes different than a primary care doctor? That is true. Does it necessarily mean that they're going to receive better care? That is not true. I know, could they receive better care? It all depends, right? There's different people in every organization. There's different people in every specialty. Sometimes you're going to see a good specialist and sometimes you're going to see a bad specialist. Sometimes you're going to see a good primary care doctor and sometimes you're going to see a bad primary care doctor. It's not necessarily their intention to be bad. They just don't necessarily have the skills that another doctor might provide in order to give you what you're looking for. And so I see a lot of doctors acting as glorified triage providers, right? It's like, oh, well, you have a heart, so let me send you to a cardiologist. And that's not necessarily the best case scenario. I explained to you before about the idea when we involve more specialists, we actually increase costs, but not necessarily improve outcomes. So it's I think, a very important idea to understand that having a good relationship with a primary care doctor that seems to be able to hear you and then give you some advice is a great tool.
And can you explain to me? Let's go to a different topic right now, because, like I said, addiction medicine. You know, this is the first time, like me, maybe one of the first time that I heard about that. Maybe some of our audience too heard about that for the first time. Can you go more explanation about what is addiction medicine?
Sure. So one of the truths about addiction medicine is addiction medicine in the past has been in the Department of Psychiatry.
Mm.
And so there has been a psychiatrist that has an additional fellowship, which means that after you do your 4 years of psychiatry, you can do an additional fellowship to become addiction medicine certified. But what we know about accessing mental health care is that there's a shortage there already, right? People have a hard time getting to a psychiatrist in the first place. And what I've experienced is that psychiatrists tend to be very, we'll use the word conservative, so that they are not interested in receiving a lot of clients that are dealing with addiction because they want to reserve themselves for dealing with their psychiatric clients. And they're not recognizing that the addiction portion of their disease pathology may be related to an underlying psychiatric problem. In my case, I believe that majority of addiction is related to trauma. And so trauma really is an anxiety related type of disorder. And so it is an underlying psychiatric disease. But underlying, where does that trauma come from can take some time to really digest. And that's actually where a therapist has maybe a better opportunity to dive in than a psychiatrist. Psychologist is more of a therapist, psychiatrist is more of a medicine doctor. And we've seen it on TV. We see the psychiatrist that does the couch therapy, but
Yeah.
that's not typically what we're seeing in practice. Most of the psychiatrists are doing the medication therapy, and it's the psychologist or the behavioral health therapist that is actually providing the couch therapy, right?
Mm.
And so then that means that there's two providers, a psychologist and a psychiatrist that would potentially provide that. And that's where, a primary care doctor can step in, is that we've been doing this in nicotine. We can do this for other disorders,
Yeah.
alcohol being a prime example. And one of the things I'll tell you is that in primary care, we see every day behavioral disorders, right? Whether it be depression or anxiety. We see somatization because they're having some kind of symptoms from other kind of traumas that are happening in their lives. And then they create, it creates some real physical manifestations of their traumas. And sometimes we don't recognize that. Even the patient doesn't want to recognize that. They're like, you're calling me crazy. No, I'm not calling you crazy. I'm just recognizing that your body is connected and that your nervous system and your body are giving us a symptom to deal with because you need some other kind of stress reduction or stress treatment, stress management. And so sometimes those stress reduction or stress treatments can include medications. I definitely use in addiction. I use a ton of medications that are not traditionally considered addiction medicines because I use antidepressants and I use anti-seizure medications and I use antipsychotic medications. And it's not because I think someone's psychotic, but because these medications are some of the medications that help reduce our stress kind of symptoms. And so these are the medications that I use on a daily to help people with their substance use. And so a lot of us are scared to enter substance use because we kind of equate it to chronic pain management. And those are really different things, right? There's no doubt that chronic pain likely also has some somatization and likely has some underlying psychiatric component to it. But there's also physiologic components. When people start taking opiates for a long time, their pain receptors upregulate and they have more pain with simple things. So it's kind of an interesting just idea that we need to step back a little bit, take a broader picture, and then evaluate the traumas that started off someone's survival behavior. And then we can start to unweave some of the traumas so that we can promote healing, because there's a difference between coping and healing. And I think addiction medicine has become a recognized specialty from the American Board of Preventive Medicine. And you can get there through ER, you can get there through IM, internal medicine, you can get there through family medicine, you can get through pediatrics, you can get there through any specialty at this point, as long as you take some time to study the material. Now there's a fellowship. So you have to apply for a 1-year fellowship. And this 1-year fellowship is kind of a short guide. Okay, these are the medications we're using, these are the addictions, this is how they work. And now let's put you in the treatment environment where you get to engage with clients that are dealing with these addictions. And then you can have some confidence so that when you finish, you can go into your usual practice with addiction. But what we're seeing is that when people become specialized, they like to focus on that specialty. And I'm included, right? I think that I get a lot of value out of providing addiction care. And so I really appreciate that. And that's actually one of the reasons why I provide or started this company, is I would like to help people to start providing addiction care within their practice without having to go to that fellowship. Because most of the medications we're reaching for do not require a fellowship to understand, right? The same way that we treat in primary care depression and anxiety, the same way we treat nicotine disorder, we can start reaching for medications to help people to treat their alcohol use, their opiate use, their methamphetamine use, their benzodiazepine use. And a lot of it is related to their underlying psychiatric traumas. And if we can unpack their traumas, we can help them move into the direction of healing.
I see that you're really passionate about addiction medicine. being I say being a champion on this kind of topic. And in what way do you see your experience and expertise helping other physicians incorporate addiction medicine in their practices?
Yeah, I think that the most important thing is sometimes we need a little nudge or a push. And so one of the services that I would like to offer practices is I can help be a support person so that when you're encountering someone, you're reviewing someone's history and you're reviewing someone's medications and you're reviewing someone's interest in receiving medications. What would I do? Well, call me, text me. I will give you that information if that's something that you're not able to find from several resources. And I can tell you what I would do in this situation. If you want to go ahead and put me on a three-way, either video or a call with your patient, and we can say, hey, this is who I am, and I've heard a little bit about you, and this is the type of treatment recommendation I would recommend in this situation. How does that sound? So sometimes it's just a little bit of a support. And I love the word you use, champion. That's how I feel like I've been able to help support other people as a champion. I've been able to help support other people that are interested but don't feel ready, and recognize that actually you don't need too much more to be ready. You just need to have the interest. And then if you have somebody that can pat you on the back or give you some additional suggestions, then you can feel confident. And so my company will be able to contract with providers or with practices that would like to have coaching for their providers to be able to provide addiction care embedded in their current model.
So just I thank you for that, and I really see the passion on that. I see really the you're very open to uh, help the physician a small help, a small step to be knowledgeable in addiction medicine, or if they want a full spectrum that really incorporate this to their practices, you are one of the people that can coach them, or physician that can coach them to practice this as they move forward on their lives, right, in their practice. So
Right.
let me shift a little bit in the topic. And
Sure.
when it comes to financial strategy or solution, what are your curious about, and how do you think could benefit physician like yourself this kind of strategies?
That's a very interesting question. I want to back up and go back to your question about early physicians, right?
Mm-hmm.
Because this is something that I didn't recognize. When I graduated from medical school, they told us about a Roth IRA.
Yeah.
And when I was in residency, I was actually making a smaller amount of money, and I could have contributed to a Roth IRA. And then as soon as I graduated residency and got on into the real world, all of a sudden my income did not qualify for a Roth IRA. So even though it was a great tool to potentially look into, I missed the boat. So I hear about backdoor Roths, and I hear about, within a business creating a contribution, and then that gets converted into a Roth. Those are the kind of things that I'd like to have more information.
Yeah, like I said, a combination of like you're offering, like you want to other physicians offers a comprehensive practice, right? So that's the way the Curious Finance comes, right? We try to see what's the connection between your goal, tax advantage, risk mitigation, investment advice, and legal and business advisory. Because, like I said, people evolve, right? And so the practice should evolve too with a person. So maybe in the future, we can discuss that in more private way, because this is about your practice. So I just want to make second and change topic again to what emerging medical trend or innovation are you excited about, and how you can see shaping the future of addiction medicine?
Well, we've certainly become a culture that appreciates immediate responses and swipes and apps.
Yes.
And so there's no doubt that there will be some continued evolving applications on our telephones, our pocket brains, that will enable us to connect with people in a fast way. There's two innovations that are really helpful for me. One of them is that AI hopefully will be taking away the documentation required that happens when you're listening to a patient, right? Because it's really terrible to be not engaging with the patient and look like you're doing something else at the same time. So if we're able to have AI take over the scribing so that we can have a real-time conversation and then have a real-time note created for us while a patient is talking, provider is talking, the AI can differentiate the different voices in the room and put them in different places, and then create a document that looks like a reasonable document so that we don't have to spend 2 hours doing those kind of tasks, using AI to do task work. Oh, somebody's medication needs to be reviewed, making sure that that gets done in a way that doesn't take a lot of provider time. And there's a lot of things that I think are tasks that can be removed from a provider. So that AI is, I think, an exciting thing. I've also seen some laws change. For example, I think it was 2022, the President of the United States signed the law that removed the X waiver for buprenorphine. And so all of a sudden, everyone with the DEA can provide that medication, which is an amazing opportunity for people who are seeking opiate replacement therapy, don't want to get to a methadone clinic. I've had a lot of people say, well, it's hard for me to get to the methadone clinic every day. It's an hour away by bus. Well, buprenorphine can be delivered. It's a Schedule III medication, which means you can deliver the medication with a telephone consultation. You can deliver the medication with a video consultation. The medication can be sent to a local pharmacy, and then the pharmacy can mail it to you, right? It's probably more safe for them to you to go pick it up, but you can go pick it up at a local pharmacy instead of going to a methadone clinic. And the medication can be delivered for a week or a month at a time, as opposed to a day at a time at methadone. So you don't have to constantly go in. And if a day at a week at a time is not a good enough interval for you, we have long-acting versions of buprenorphine that last a month at a time, right? So you can have an injection once a month and have that medication on board and help reduce your likelihood of reaching opiates. So that's an amazing thing. The law has changed so that the government has recognized that you can provide a virtual or telehealth consultation safely to be able to provide this medicine. So barriers for access to medication are currently changing, and that's amazing. So I'm really excited that, between the technology and then the laws to reduce barriers, we're having a great access to the opportunity to provide this kind of care.
Like I said, doctor, I've been talking for a while here, but I think the more you talk, the more I get like thinking what I can I have more questions, but I know you're a busy man that many people may want to basically connect with you. If for your colleague in the industry who wants to learn more about your work, what are some ways that they can connect with you and explore collaboration?
It turns out that an email is not something that I connect with very quickly. I do review my emails on a daily basis, but a text is in my hand almost all of the time, unless I'm playing baseball or in a movie or in a water park, right? I'm not going to be able to have my phone with me at all times, but I will definitely respond to a text fairly quickly. And that email has really been inspired by the idea that change is possible, and change in the opportunity to heal is really what I'm trying to focus on, recognizing that medications are not the long-term treatment to our personal connections. I love a quote from Gabor Mate. It says, "The opposite of addiction is connection." And so I think it's really important that connection means connection to ourselves. It means connection to our community. It means connection to our families. And so if we can move in the direction of connection, we will have a lot of tools to help us to deal with our coping behaviors. Because one of the most strong emotions that leads us towards substance use is loneliness. And when we feel lonely and abandoned, when we're using these substances, we actually only isolate ourselves more.
And like I said, I put in the big screen your number and your email. Hope that hopefully more people will write it down, and if they have question about you, about your practice, about your company, and they can definitely reach out to you. And for the conclusion and for closing, sir, I just want to know, doctor, what can you advise the physician, like I said, that is contemplating about including addiction treatment to their practice?
The good news is there is a ton of free resources and education. And if you would like to have a connection to those resources and education, I'm happy to share those with you. If you feel comfortable going ahead and doing the self-learning, you can do that. And what I would like to offer is like the backup plan. So like if you're actually seeing a patient and you need some assistance and help in the moment, that's where the coaching comes in. Give me a call, give me a text, send me an email. We can review the case, and then we can decide, okay, well, what did you decide to do? What did you talk about? And maybe what I would have considered, because it's not about a one size fits all. What I love about the idea of medicine is that we have evolved over time. I love that word that you use, evolve, because if we are static, we're not changing. That's why change is actually in my symbol. If you see the delta sign is in my addiction change experts. The truth about change is growth. Change is an opportunity for growth, because we don't always change in a growth way, but change is an opportunity for growth. And in this case, change can be an opportunity for healing. And so if we can change some of our behaviors, really, this is all about lifestyle. This is all about how we deal with our emotions. So recognizing that our emotions are our drivers of behavior, and if we can change how we acknowledge that emotion and then how we respond to that emotion, we can change our behaviors and live healthier.
Yeah. I mean, before we close, I just cannot um, tell myself to tell you that you may be a good dentist too, because your smile are very, very good and nice, and I like that. Yeah. So like I said, for our televiewers right now and audience that watch the behind the stethoscope today, and we have more doctors that gonna be on board in this um, YouTube channel series. And hopefully, if you still not subscribed, please subscribe. And like I said, the most thing about this is connecting to our doctors that we interview here, because they have a tons of knowledge, tons of ways to help you become better in your life. Again, this is Ronald Flores from Behind Stethoscope. Have a good day.